This is IAQ Radio, Indoor Air Quality Radio, the voice of the indoor air quality industry, with your hosts, Radio Joe Hughes and the Z-Man, Cliff Zlotnick. And now, Radio Joe Hughes.
Good day and welcome to IAQ Radio Plus. This week is episode 656, and we welcome back Dr. Lisa Brosseau. We're going to discuss respirators and masking. After 2 years of research and real-world experience, what have we learned and what should we be doing in the future? Before we get started, we want to thank our sponsors. They're the reason we can continue doing the show. And don't forget about Afterthoughts after the show at afterthoughts.iaqradio.com, sponsored by First On Site. Our marquee sponsor is Instascope at instascope.co. Our association sponsors are the American Industrial Hygiene Association, AIHA.org, the American Conference of Governmental Industrial Hygienists, ACGIH.org, the Cleaning Industry Research Institute, CIRI Science.org, the Indoor Air Quality Association, IAQA.org, the Institute for Inspection, Cleaning, and Restoration Certification, IICRC.org. Industry sponsors are AEML Laboratories, AEMLINC.com, Particles Plus, ParticlesPlus.com, TSI Inc., TSI.com, Sunbelt Rentals, sunbeltrentals.com, April Air, April, AIRE.com, Healthy Indoors Magazine, healthyindoors.com.
And now you can win a cool prize. It's time for the IAQ Radio Trivia question. Be the first to correctly answer. Simply email your answer to czlotnick@cs.com. Or if listening live, just text your answer from your computer. And now, here's the Z-Man.
Hello, everyone. I'm glad to report that Jack Springston, Atlas Technical, New York City, was first to identify mold as what by the early 1990s had become the top complaint of occupants in non-industrial workplaces. The IQ Radio trivia question for today, March 4th, 2022, has been sponsored by TSI Inc., an industry leader in the precision instrumentation of the monitoring of indoor air. Learn how to expand your IQ investigations at tsi.com. Here's today's IQ Radio trivia question. Intended to minimize worker exposures to hazardous chemicals and other risk factors in the workplace. An international example of this concept in use is the procedure for the transportation of dangerous chemicals, whereby chemicals are classified with United Nations or UN codes that are used for identifying safe storage rules, permitted types of transport containers, and actions to take in case of an emergency. Name the concept. Back to you, Joe.
We better put that one in the chat there, Cliff.
That's a long one. I'll get it.
All right. Dr. Brosseau, now retired, was a professor at the University of Illinois at Chicago School of Public Health, where she was the director of the Illinois Education and Research Center, which supported graduate and continuing education for occupational health and safety professionals. She began her career as an academic researcher and educator at the University of Minnesota School of Public Health, where she directed the Industrial Hygiene Program. She continues to serve as a mentor and technical advisor on research projects and for businesses and organizations, including the Center for Infectious Disease Research and Policy, CIDRAP. CIDRAP is a center within the University of Minnesota that focuses on addressing public health perspectives and emerging infectious disease response. Welcome back, Dr. Brosseau.
Thank you, Joe. Thank you, Cliff. Glad to be here.
It's great to have you back. The last time we talked about the answer to the quiz, so I'm not going to say it. I just caught myself. But this time we want to focus more on what, was kind of your passion, and your early research was all on respirators, or a lot of it was on respirators. And I was wondering if we could start out by maybe doing a little brief history of respiratory protection.
Sure. Respirators actually go back, I think, thousands of years to the Romans. They've got descriptions of people wearing pig bladders and other strange things on their heads in mining. But sort of modern respirators kind of came about in the late 1800s, early 1900s. Mining, warfare, using chemicals, and then of course industrialization really sort of pushed the development of better respirators and more innovative designs that workers could wear, to protect themselves from a lot of hazardous materials. And then, so the Bureau of Mines was the first certifying or regulating organization in the United States for respirators. Eventually, NIOSH, after the 1970, put together both OSHA and NIOSH as regulatory agencies or as research agencies. NIOSH took over eventually the regulation and approval and certification of respirators. And so they're responsible for that. And there's been a lot of interesting developments in respirator design over the years. Probably, we started out with things like elastomeric respirators in industrial settings and added cartridges that were good for many different chemicals, and then eventually got some pretty good filters. I was telling Joe and Cliff before we got started, I did research on these old electrostatic filters that were made from resin impregnated wool, called dust mist fume filters. But I think in the 80s, we began to see 70s and 80s, we began to see much better filters. And now we have electret, spun non-woven filters that are very, very effective. So lots of changes, lots of improvements in design, fit, testing, et cetera, over the years.
When we talked earlier, you had mentioned that over the past 20 years, respirator use in healthcare has been a focus, I think, of NIOSH. I wonder if you could talk a little bit more about that and why it's become such a focus.
I think it started really around the time of tuberculosis, which was late 80s, early 90s. So when I was coming of age as an academic, and there was, because of HIV, tuberculosis was a problem in terms of patients because they were susceptible to many different diseases, and became an occupational problem because nurses and and healthcare workers and correctional facility workers and others were exposed, and some even died from exposure to tuberculosis, which really wasn't a disease. I mean, it's endemic in other areas of the world, but certainly not in the United States. And I think that really pushed NIOSH in the direction of trying to understand better what we need in terms of biological aerosols. And then along came, many other problems, and novel H1N1, SARS, MERS. All of those are, they impact healthcare more than they impact the rest of the public, so to speak. Even Ebola, it was more of a healthcare problem than it really was a public exposure issue. And I think healthcare has one disadvantage, which is that they've relied on surgical masks for so many years that it was really hard to convince them that surgical masks are not respirators. They don't provide respiratory protection. So that's sort of the battle that I have found myself fighting for most of my career, is trying to encourage and improve the use of respirators and the acceptance of respirators in healthcare settings.
And when you say that surgical masks are not really respirators, I think they're considered like a source control. Is that accurate?
That was their original expectation and design, is that they were worn in surgery to prevent emission of bacteria from the people who are doing the surgery, speaking, talking, breathing, and prevent the infection of wounds or of open wounds. Unfortunately, surgical masks actually proved to not be very effective even at that. There have been a few studies that demonstrate they don't really change the wound, the surgical infection rates. But they later became something that people would wear also to protect them from splashes and sprays. And so there are some who argue, well, it does provide some personal protective equipment. When people tell me that, I often say, would we ever use a surgical mask in a chemical setting or a laboratory to prevent splashes and sprays? Probably not. Goggles, face shields, other things like that will do a better job. But the surgical mask is sort of, as one investigator wrote, it's sort of a sacred cow to the healthcare industry, and it's hard for them to give up, despite the evidence that it doesn't really provide any inward. It certainly doesn't prevent inward leakage and inhalation of hazardous aerosols, especially smaller particles.
And yet we still see them used today with people who are working with COVID or possible COVID patients.
That's right. Yeah, it was early on. Respirators, CDC actually all throughout the pandemic required that anyone providing care for, direct care to COVID patients, suspected or confirmed, should be wearing a respirator, at least an N95 filtering face piece respirator. And the patient should have a surgical mask on, which seems a reasonable expectation. But eventually they decided to recommend universal masking in all healthcare settings, meaning everyone had to wear a surgical mask. And in retrospect, I think it would have been better if we had had the supplies, especially early in the pandemic, that everyone should have been wearing a respirator. And we could talk a little more about that coming up.
And we're going to. All right, let's start with the N95, N99. Well, N95, there's N, R, and P.
Right.
No oil resistant, oil proof, as I understand it. 95, 99, and 100. First, let's get a little background on the difference between 95, 99, and 100. Is it a different material? Is it woven differently? Is it designed to fit differently?
It depends on where the filter is, whether it looks very different. An N90, a 99 or 100 as a filter in a filtering face piece respirator probably won't look much different, but it might be somewhat thicker. In a cartridge, like on an elastomeric respirator, it might be a folded material, because the problem as you increase the efficiency is you also increase the breathing resistance. And so you fold the filter to get more surface area to lower that breathing resistance. So, when we talk about HEPA filters, those are 99 and 100 type filters. You usually see that they're highly folded, right? In indoor air filters, certainly they would be highly folded. I will tell you though, for most of the workplace exposures and aerosols that we encounter, a 95 filter is actually very good. They're really over-engineered in many ways, because the test requires that you test at 85 liters a minute, which is way beyond what most people breathe, except if they're working very, very hard, say in a construction job. So, most of us breathe at about 10, 20, maybe 30 liters a minute. That 85 liters per minute test at the most penetrating particle size means that when you're breathing at your typical breathing rate, you're going to get much better, higher efficiency for a filter. And so the reason for the 99 and the 100 has to do more with how toxic the material is and how much we worry about any amount getting through the filter. So while I say a 95 has a lot of efficiency, a 99 and 100 will be even more efficient. But you do have that trade-off of breathing resistance for those filters.
And so I assume that is why the N95s are more popular, more commonly used. You rarely see, R99s or P100s, except in occupational situations. But I still wonder, though, with people dealing with COVID in a hospital, they're dealing with a COVID patient. It doesn't seem to get much more hazardous than that. And they're still in maybe an N95 if they're lucky.
It's in the context of protection, the filter is not the thing I worry about, especially not for COVID, for respiratory droplets or aerosols. Most of those are relatively large. Large is in the context of aerosols. They are around 1 micron, which is collected quite well by any filter, any of these respirator filters. But the real issue is a filtering face piece respirator can have a certain amount of leakage around the face, right? Because the assigned protection factor for that class of respirators, a half mask air purifying negative pressure respirator, is 10, which means that it reduces the outside concentration by 10 times for the inside, or another way of thinking is the inside concentration is 10 times less than the outside. That's still a certain amount of leakage around the face piece, which with a hazardous aerosol, it could be that's where you could be concerned. It could be, and if the concentration is very high, you could get quite a dose in a very short period of time wearing a filtering face piece respirator. So that's really why, occupational hygienists recommend that we go to something better when you're doing something like an aerosol generating procedure, or you're with somebody who's very infectious and symptomatic. That would be something like a powered air purifying respirator or a full face piece elastomeric respirator. Those things will have better, higher protection factors. So it's not the filter really that I'm worried about. And NIOSH or CDC said, with input from NIOSH, I'm sure, that if you didn't have an N95 and there were lots of shortages early in the pandemic, you could use any filter, and they were right about that. Any filter would have worked fine, and you could use any type of filtering face piece respirator.
I've got a follow up if I could.
Sure.
Gosh, I've been in this industry for a long time on the remediation side, and I was familiar with N's and P's and so on and so forth, because that's what we had in the United States. And then all of a sudden, when we had COVID, all of a sudden these filters start showing up that I suspect were made overseas, that begin with K and begin with other initials. And how do they compare? How are they different? Someone had told me it was face shape is different, for people in the United States than, people from Asia and so on and so forth. Can you straighten us out on that?
Again, you have to think about both the filter and then the design of the face piece as something separate. So let's talk the filters, and I am not an expert at all on the testing methods from other countries, but I have read a little bit about this. So the KN95 is a Chinese made and Chinese certified or approved filter and mask or respirator. And those, NIOSH did testing of a variety of KN95 filters and respirators throughout the pandemic and posted the results on their website. The Chinese method of testing is not very different. It's from the NIOSH one. So the filter is pretty similar as long as it's not fake. And that was part of the problem. There were a lot of fake respirators calling themselves, KN95 or even N95 for that matter, that were really not. So, when people asked me what should I do, I said, at least for an N95, check the certification list on NIOSH's website to make sure that it has all the markings on the respirator that you expect to see, the TC marking for the approval, for example. But you could also test or check the NIOSH website for whether or not they tested any of the KN95s to see what they found. And some of them were just as good, and some of them were not quite as good. So, it was important to look at that. But the other issue with most of those KN95s is that they are ear looped. not straps. And while ear loops are quite comfortable and people like them, and I will admit to wearing ear loop respirators during the during the pandemic for short trips, down to the mailbox. But the ear loop it's very difficult to get a good face seal, and even if they're adjustable, really it's only when you take the ear loops and sort of hook them with something behind the head that you can start to get a really tight fit. And so that's the problem. Straps will give you a better fit than ear loops in most cases.
One other follow-up, if I might. Recently I had to visit someone in the hospital, and one of the things that I noticed is a lot of the hospital workers seem to be wearing a mask with a different shape. It almost looks like a beak or whatever. Yep. Can you just comment on that?
Oh, filtering face piece respirators come in all sorts of shapes and sizes these days.
Okay.
There are flat folds, duck bills, they've boat shaped, they've got all sorts of names for them.
Okay.
The key is if they're certified, then what you want to see is marking on the front that says N95 with the TC number. And then that is a real NIOSH certified respirator. But yeah, they come in wild shapes these days, and with some come with all sorts of coverings on them. Some to keep the shape better, some to protect the outside of protect the filter, so you can reuse it. Lots of changes, lots of differences in the inside features to help them sit better on your face. The thing is with these ones that are flat fold that fold out and seem very large, those are actually very comfortable for the same reason I just talked about. They have a lot of surface area, plus they have a lot of volume inside, which is more comfortable than if you ever compared wearing one of those with wearing a cloth mask tight against your face. The difference in terms of how uncomfortable a cloth mask tight against your face is. What you want is some volume that you can breathe in and out of.
Thank you very much.
Sure.
I think before we move into a little more on masks versus respirators, let's talk a little bit about the effects of factors such as sweating, heavy work, beards, etc. With an N95 or an elastometric respirator, how important are those factors, and how much do they reduce the protection you get?
So the research on beards is that they do impact fit. Even a little bit of beard can impact fit. It isn't predictable, however. So for some people it may be very little, for others it may be quite a lot. So the policy is people should be clean shaven. We have no way of knowing whether your beard is going to impact your fit or not, and we think it probably will. So that's the sweating, and there were a number of healthcare workers that complained about face injury, facial and skin injury. And that is a possibility, certainly, from wearing a respirator over time, especially if you wear it tightly, pulled quite tight against your face. And there are some skin protectants that some people have used. There's not a lot of research on those in terms of how they impact fit. I've started to see some more research on that in the literature recently. So I do think we will start to know more about the impact of and that's caused both by pressure as well as by sweating and by the temperature, a high temperature and relative humidity inside of the respirator. If we could have figured out how to use respirators that had exhalation valves, and the worry there was that the exhalation valve would release infectious particles from the wearer. But if we could have figured out how to make, to use respirators, either filtering face piece or elastomeric with exhalation valves, those are much more comfortable in terms of, the buildup of temperature and pressure, and might even help alleviate sweating in terms of the wear on the face over time. But those were banned from healthcare, and I think a lot of
Aviation,
mask
too.
mandates and others said you couldn't wear something with an elastomer, with the exhalation valve.
Another question that comes up quite a lot is how much of a health issue is just wearing a respirator all day, whether it's a kid in school or a guy doing asbestos abatement, working his rear end off, lugging heavy bags in and out. How much does wearing a respirator affect their health?
Yeah. I'm not a physiologist, and I've read the research. From what I can tell, and from the NIOSH guidance, there's really very little impact on one's physiologic, well-being from wearing a respirator. But we all know that putting something on your face and wearing it for long periods of time, there's a certain amount of discomfort associated with that. What I also know is that you have to be acclimated, and over time, wearing a respirator can get easier. So it's that sort of initial wearing first week or so that really can be, people will complain about that. Certainly, there are those who feel a certain amount of claustrophobia when they put something on their face. That evaluation of that, or of whether you have medical conditions, cardiac, breathing, whatever conditions that put you at some risk when you wear a respirator. Those are the things that a medical clearance should be able to evaluate. And anyone who's wearing a respirator in a workplace should be evaluated for medical, by a medical professional for any issues that they might have in terms of putting a respirator on. But filtering face piece respirators in particular are not particularly, they don't really put a great deal of strain on you. And you can always take it off. I mean, you can always leave the space and take it off if you have to.
And I think that question will become a little more important as we talk about wearing respirators with or without fit testing and medical evaluation. And so that's why I wanted to set that up here early. Now, the next question we had was respirators versus masks. And I know we're going to go into this in a lot more detail when we go into one of the documents here, the commentary on what can masks do. What is the current science on what masks can do with respect to assisting us with things like COVID, or maybe even just like, I remember when I was in my younger days, in my 18 to 22 range, I did a lot of roofing, and I did a slate roof tear off where we tore off the old slate tiles, and it was a very dirty, dusty job. So we would wear a bandana over our face, and actually I found that it helped quite a bit with at least the amount of stuff that I was blowing out of my nose and coughing out of my lungs. But I'm curious what we have found so far right today with respect to using masks and whether they're helpful or not.
Good question, Joe. So, that bandana you were wearing it can do a good job with really big stuff, so and when you're crushing something or banging on stone, you're creating a lot of dust, which is quite large in size. And all that large stuff is being thrown up into your face. So you're protecting yourself from all of that. The problem with COVID is it isn't exactly like that kind of exposure. When people exhale, whether they're breathing, talking, coughing, sneezing, whatever, they exhale a lot of small particles and also some larger ones, especially if they're coughing or sneezing. Those particles if you're infected, can contain the virus. And as I said, a large quantity of them will center at around 1 micron, and many smaller as well. Well, those are captured by filters, but they are fairly well, but we have some problems in terms of catching that size when there's a lot of leakage around the face, and wearing a cloth mask tightly against the face, and 2 layers was the recommendation from CDC. What CDC didn't understand was, or didn't, reflect accurately, was that's a very difficult thing to breathe through over time. Cloth is not designed, I mean, if you want cloth to be very efficient, you just need to keep adding layers. But the more layers you add, the harder it is to breathe through. So when people wear cloth masks over time, you see them moving their mask under their nose or even under their mouth because they just can't deal with the breathing resistance. They're uncomfortable. So there's leakage both inward and outward from a cloth mask. And the same is true for a surgical mask, which is certainly not designed to fit well. And most of those have lots of gaps around on the sides, on the top, on the bottom. So if we are worried about the early messaging about face masks or cloth masks was you're protecting the people around you. And that may be true if all of those large droplets are captured as outward. I think there's unfortunately a lot of leakage around the side of a cloth mask or a surgical mask. And it's those smaller particles that stay airborne and expose people. But the other problem I have with that message, and I had all the way through the pandemic, is it makes us blame other people around us who are not wearing a mask because they're not protecting us. And instead of suggesting that we wear something better like a respirator, which offers both source control and personal protection, that would have been a better way to get people to wear something and wear something more effective so they protect themselves as well as each other. I think we could have had a lot less animosity about wearing respirators, really, than we've had about wearing masks. And when we've looked at the mask studies, community studies, they don't really show a whole lot of efficacy in terms of protecting people or preventing transmission from person to person.
What I'd like to do is let's take a little break for our halftime here. And when we come back, I'd like to pull up the document that we referenced here and go into a little more detail on that topic. So we'll be right back with Dr. Lisa Brosseau, our marquee sponsor, Instascope. More jobs done faster with the future of IAQ assessment technology. Unlimited samples, instant results, and cloud-based data at instascope.co. Association sponsors are AIHA, Healthy Workplaces, A Healthier World, AIHA.org, ACGIH, Advancing Careers of Professionals in Environmental Health, Industrial Hygiene, and Safety, interested in defining their science, ACGIH.org. The Cleaning Industry Research Institute, see more deeply through science and research, CIRI science.org. The Indoor Air Quality Association, IAQA.org. The IICRC, a nonprofit standards development and certifying body for the cleaning and restoration industry, IICRC.org. Industry sponsors are AEML Laboratories, free shipping, great pricing, same-day results with no rush fee, AEMLINC.com. Particles Plus, feature-rich particle counters and air quality instrumentation. Count on us, particlesplus.com. TSI Inc., an industry leader in precision instrumentation for monitoring indoor air. Learn how to expand your IAQ investigations, TSI.com. Sunbelt Rentals, availability, reliability, and ease for all your IAQ and restoration needs at sunbeltrentals.com. April Air, healthy home, April, AIRE.com. And Healthy Indoors Magazine, a free online magazine for industry professionals and consumers, healthyindoors.com. All right, we're back for the second half of our interview. We're talking about respirators versus masks. What have we learned from the COVID-19 pandemic? And John, if you could pull up that document we mentioned, I'd like to talk a little bit about a document from the CIDRAP, who we mentioned earlier, commentary on what can masks do, part 1, the science behind COVID-19 protection. And when we pull that up, Lisa, if you could just kind of walk us through the document a little bit and give us some of the key highlights.
So if you go down towards the middle of the, this whole article, we do a lot of discussion about the differences between respirators and surgical or medical masks and cloth masks. If you go down a little bit further, there's a table that illustrates and discusses some different, tries to illustrate the differences between these different things that people put on their faces. And this table actually was first published in an ACGIH fact sheet that I helped develop with a COVID-19 task force about a year ago. And then we adapted it for the CIDRAP commentary. And the difference here is that I added non-fit tested respirators in addition to fit tested respirators to the table, because this was geared towards not just workers, obviously, but to the public. And I was trying to illustrate that the public wearing even a non-fit tested respirator is likely to get better protection than any of these other things that were being recommended. So let me just quickly give you sort of an overview. This is a table that describes how long does it take for someone who's not infected to get an infectious dose. Now, we don't really know what the infectious dose is for, SARS-CoV-2, the virus. But we do suspect it's fairly low. And rather than trying to model on the basis of an infectious dose that I don't know much about, I decided to take a simpler view, which was the CDC recommends that you would assume that someone could be infected if they were in close contact for 15 minutes for a collective amount of cumulative amount of 15 minutes over 24 hours. And so I took that 15 minutes as the time you would have to get an infectious dose if you were both people are wearing nothing. So the source is wearing nothing and the receiver, the person who's not infected, is wearing nothing. And then I just tried, and then the 15 minutes is simply, you simply divide that amount by the fractional efficiency or leakage of a mask or a respirator. So if the source is wearing nothing, but the receiver is wearing a cloth mask, so the uninfected person has a cloth mask on, they might get about 20 minutes of time. If they're wearing a surgical mask, which has typical one has about 50% inward and outward leakage, they might get 30 minutes. If you put on a non-fit tested respirator, you move up into the hours. And if you wear a fit tested respirator, even more hours. Not 8 hours though, keep in mind. If the source is, if you're standing near the source and spending time with them. So an fit tested N95 filtering face piece respirator is good for the direct care of patients as long as you limit the amount of time that you spend with those patients.
And then as you move down, and let's say that both the person who is treating the patient, let's say, and the patient is wearing a mask, right. Then you could walk us through that.
Sure. So let's say we're talking about a patient. So the source is wearing what was recommended for suspect and confirmed patients was to wear a surgical mask if they could. So that's on the left side, the 50%. If you follow that across to the healthcare worker wearing a fit tested N95 respirator, you see that they get about 5 hours. So each of these things has some efficacy. The reason I put this together was to illustrate for people that they should not count on a cloth mask or even a surgical mask to give them hours and hours when they are in closed spaces with people whose infection status they don't know. And obviously, the more people, the greater chance that one or more people is a source. And so one of the caveats for this, and we added a whole bunch of points to this to this table recently, because I was getting so many questions about, why don't you do this? Why don't you do this with it or that with the table? One thing I wanted to be sure is that people understood, don't count on these numbers as, bright lines between safe and unsafe. So, don't assume that you go into a space and you're wearing a surgical mask and now everyone else is wearing nothing, that you're going to get 30 minutes. It doesn't take into account the ventilation in the space. It doesn't take into account the number of people. It doesn't take into account that's the size of that space, and it doesn't consider what those people are doing. If they're, singing or talking or shouting, there's much more aerosol. So, but the idea is to illustrate that with a mask, a cloth mask or a surgical mask, you get minutes, and with even a non-fit tested respirator, you start to move into a much longer time period when you might be protected.
And I think when we talked earlier, you felt that it was a little surprising, but not a lot, that the non-fit tested N95s would really give us a lot better bang for our buck, for lack of a better terminology, than what we ended up doing, which was, double cloth and, some people using surgical masks. I mean, personally, my double cloth mask that I made and put a clip on, I feel is much better than a typical surgical mask. So there's going to be, variations on these numbers, but this is giving you an idea so that you can kind of compare, okay, if I'm wearing this and the other person's wearing that, this gives me some idea. And I think the area where you talked about that really struck home with me was, and I guess the key word is home. A lot of this, if not most of the infection, occurs in households. Is that accurate?
I don't know if most, but the estimates are somewhere between 20 and 30%. And of course, we don't know how many people actually were infected because there was so much asymptomatic and pre-symptomatic transmission, and we may never know. But even if it's a fourth to a fifth to a third of the transmission that's happening, there really wasn't a lot of focus on wearing a mask or anything in the home. The recommendations were to, separate yourself from someone, but that's not easy in the context of a home setting, especially if you have to care for someone, right? So really, it would have been better to recommend masks and even non-fit test, better even to have a non-fit tested respirator in a home setting. The thing is, exposure involves all the time you're exposed. It isn't just when you're out, going to the restaurant or shopping. It's all the time you're in contact with people. And so it's home, it's everything you do. Anytime you're in contact with people, there's some exposure, there's a risk, unless all those people are staying home. It's like that's the key. And so we can't leave out that home exposure in thinking about transmission.
Very important. And the other thing I wanted to ask is, what would have been successful on masks? So looking back at what we did, and it, like you said, I agree that we kind of had it backwards. We should have been protecting ourselves instead of telling people to protect other people. I understand that. What else might have been successful, and what lessons have we learned?
One of the things that NIOSH has been doing research on in the past 4 or 5, even maybe longer time period is whether we can, first of all, design better and then implement the use of elastomeric respirators in healthcare settings. And if we had that, if those had been in the stockpile, if healthcare workers had each had their own elastomeric respirator, handy, if they'd been fit tested and trained on how to wear them, we could have alleviated immediately all the supply issues with respect to N95 filtering face piece respirators, which are worn once in healthcare and thrown away. I know in other industrial settings or other workplaces, we discourage the wearing once and throwing away. You can wear them at least 5 to 10 times. But an elastomeric respirator you can wear many, many times. A single one would have lasted a healthcare worker all the way through the pandemic. And then think about what we could have done with the supply of N95 filtering face piece respirators. All the rest of the healthcare workers or people working in healthcare who weren't as highly exposed as those caring for patients could have had an N95 and not a surgical mask and not a filter, not a cloth mask. And then think we could have even had supply available eventually as we ramped up manufacturing for the whole population, and especially for workers in other settings who were also at risk in essential workplaces. So that could have happened by the end of 2020 if we had started with elastomeric respirators, but we didn't start with elastomeric respirators, and we didn't even start with enough N95s. So we were sort of stuck from the beginning. And it's unfortunate because we really know what will work in healthcare.
And what's a shame is we still aren't there.
No, we're still not there.
The healthcare industry needs to get on board and get proper respiratory protection, period, whether it's for COVID or a biological weapon or TB or whatever it could be, the
Yep.
SARS and MERVs and all that other stuff. And it's frustrating as heck to see them not doing that.
Yep.
So
somebody you might invite to come in to talk about this is Dr. Stella Hines at the University of Maryland Medical Center. They've been using elastomeric respirators since 2009, since the novel H1N1 pandemic, which was a very limited pandemic, but they basically decided to adopt it. And she's done a lot of research on how to make that work. And they've been using elastomeric respirators throughout the pandemic very successfully. It'd be really good to hear from her. How did they make that work?
Absolutely. I'll definitely follow up on that. Now, there's a text question I think kind of leads into something else I wanted to talk about that he found ironic and wrongheaded during the pandemic was professionals who argued that for public, an N95 respirator would be less effective because they couldn't be fit tested. And that assumes cloth mask or surgical mask is well sealed, which they're not. Your research shows that even non-fit tested N95s provide significantly more filtration efficiency. Would you agree with that?
I did a study so FDA had a regulation on the books. It's still on the books, but it doesn't seem to have played a role in the pandemic, that a respirator manufacturer could have their respirator certified or cleared for use by the public during a public health emergency. And there were several of those on the market for a number of years. I helped a company evaluate one of those, their respirator, by recruiting a panel of subjects that met the NIOSH bivariate panel requirements. But the subjects were completely untrained, meaning they did not know anything about wearing a respirator, and we didn't train them. We just gave them the instructions, the manufacturer's instructions, and had them wear the respirator. Now, they don't get the 100 by any means that you would expect, but quite a lot of them got a fit factor that was better than any fit factor you would get with a surgical mask or a cloth mask. So it did suggest to me, and the reason for that is really twofold. One is really, really good filters. Respirators have great filters, right? And the other is they are actually designed to be fit. I mean, yes, we have to do fit testing in workplaces to be sure, but they are inherently better designed to fit than any cloth or surgical mask. So with just some basic instructions, most people could get them on correctly. We did have we did make some observations about people putting them on, and one or two didn't quite get them on the right way. A lot of them had problems getting the straps in the right place or forming the nose clip. Those are the kinds of things we could have taught the public during the pandemic. We could have had any number of videos, or the president even could have demonstrated how do you wear a respirator, right?
Right.
It would have been easy.
Pictographs. Yeah.
All sorts of ways to demonstrate this. And even when we didn't make a whole lot of effort, people did pretty well, and they got much better than I've ever seen with a surgical mask or a cloth mask.
Now, I'm thinking one pushback you might get, and particularly from the industrial hygiene community, is that you're issuing a bunch of respirators without medical evaluation.
Right.
What's your response to that?
Yeah. I think, as I said before, N95 filtering face piece respirators are really not the most onerous type of respirator to wear. It's other classes of respirators that put more physiologic strain on you, especially as you move towards like a self-contained breathing apparatus, for example. The N95 filtering face piece respirator has relatively low breathing resistance, especially the better ones, the better manufactured ones. And they are more comfortable than I think a lot of people have had experience with ones that either didn't fit well, had high breathing resistance, and there are a lot of them, unfortunately, still on the market. I think NIOSH is working hard to change that with regulations. But I've worn very comfortable filtering face piece respirators. So I think it is possible to find one that fits well, is comfortable, and that you can communicate with. That's another important thing that really doesn't put a lot of strain on you physiologically.
Especially for people like teachers and others that need to communicate. And I guess, well, let me do this. Let's go to the roundup, and we'll get a couple more questions before we have to wrap it up.
Sure.
The roundup is brought to you by April Air, providing healthy humidity, ventilation, and air purity solutions for new and existing homes. April Air, healthy air, healthy home at aprilaire.com. All right, Cliff, let me ask if you have any final questions or thoughts.
I just have a final comment. And, I think we've all heard all these pros and cons about wearing masks and whether kids should wear them or shouldn't wear them in schools and all this other stuff. And I think the most compelling thing that I heard was recently, it was last week, they were talking to a teacher, and this particular teacher was a speech teacher. She helped kids that had speech impediments in school, and she had great difficulty because typically this type of teacher would demonstrate with her mouth the alphabet and the pronunciation and so on and so forth, and she was just really at her wit's end, trying to demonstrate, what she needed to demonstrate. And that to me, was the most realistic, situation. I thought that, what she encountered was undeniable. All the other stuff, I think, you could be on either side and have an opinion, and so on and so forth. So I just wanted to mention that I guess there are going to be some kids that are going to be a little bit behind in speech as well.
Let's go back. I do want to mention the other document we talked about. And I don't know if, John, if you could go back to that website we were on just a moment ago. And it was what makes a good mask study.
So part 2 was, and I partnered on both of these with a number of very good epidemiologists, Angie Ulrich, Kevin Eskandon, Corey Anderson, and then Mike Osterholm, who lead CIDRAP. And what we did is we took some of those studies that everybody was really hyping, especially in the press. One of the one study that's most hyped is the one from Bangladesh, but there are others as well. We took a bunch of those and we sort of looked more deeply into what did they really tell you, what was really done. And what we found was that there were a lot of problems with these studies, and they're understandable problems, because one of the issues is, how do you do a study of masks without all the other things that also went on? How do you just have masks when there are so many other interventions? People stayed home. People were being careful about who they were interacting with. So one of the really key problems I found with all of these studies is we really didn't know much about people's exposures. And the assumption was that everybody had the same exposure, whether they were wearing a cloth mask or a surgical mask or whatever, or nothing. Well, that's clearly not the case. And there was no effort to evaluate exposure to see whether or not there was equivalence. And there wasn't really an effort to try and evaluate the confounding that is brought about by multiple interventions. And particularly if somebody is wearing a mask, they're also probably being careful in other ways, right? So you have that part of that sort of bias as well. And the outcome measures that they were using, seropositivity, for example, in the Bangladesh study, they didn't measure seropositivity at baseline, and assumed that when they measured seropositivity, meaning antibodies in your blood, that occurred after sometime during the study period. But really, that could have occurred well before the study period, especially since the Bangladesh study was done toward the end of 2020. So we sort of picked apart a lot of these studies, and at the end of the day, we couldn't really find one that did what we hoped it would do, which was to demonstrate any efficacy. So this is face masks for COVID passed their largest test yet. A rigorous study finds that surgical masks are highly protective, but cloth masks fall short. That was in Nature, and that was the Bangladesh study that was being hyped. This was being hyped even before it was actually published, which really annoyed me. That's another thing we said. We really need to stop focusing on preprints or even on people who go to do press releases with their data before it's ever been published or even put into a preprint. We need to be more careful. This next study was the headline. We picked the headlines and then talked about the studies themselves. We studied 1 million students. Well, first of all, they didn't study 1 million students. There wasn't anything like 1 million students in this study. But that's what the New York Times does to get you to sort of read the article, right?
Right.
But this was a guest essay by the two people who were the researchers. I can't imagine they were happy when they said, 1 million students. But actually, the study had many problems with it as we began to read through. And it didn't separate out infections for staff versus students, for example. So, and we know that staff were at much greater risk than students ever were, unless they had comorbidities or were at risk, for health because of health issues. Adults are much more at risk from COVID-19 and have been throughout especially for serious outcomes throughout the pandemic. So that's what this article was about. And actually, our group is now working on we're going to take this sort of approach and these studies, but others, and develop a peer-reviewed publication that tries to do the same thing, but try to reach a bigger audience in illustrating for people how difficult it really is to do a study like this during a pandemic. And I was telling Joe when we talked about this earlier, early in the pandemic, Angie and Mike and I sort of brainstormed, well, how would we do a study? How would you do a study for masking? What would you need? What would that look like? And I kept saying, I have to know what people's exposures are, so I can know that they are equivalent for the masking group versus the non-mask group, right? And the only group I could come up with where I could actually have some control over that, or some information about that, would have to be workers. It would have to be a workplace. And I said to Mike and Angie, we should go to Target and talk to them, because they've got so many stores around the country. We could pick a store where they did have masking, and we could pick a store where they didn't have masking. And but we could know so much more because we know a lot about people's exposures when they're working in Target. We know what that exposure is like. So we could have said, oh, those people would be very similar. Let's see what masking did in terms of infection rates. But that wasn't ever thought about when people were doing these studies. And we never actually had the time and the resources to do that kind of a study. But if I had, that's what I would have done.
So let's finish on a positive note. What are some of these good things that have come out of this pandemic? And then if there's anything you'd like to add before we wrap it up, please let us know.
Sure. Well, I think from a respirator perspective, and since that's my area of expertise, I think there has been more innovation in respirator design in the last 2 years than there was in the 20 years before. It's been somewhat astonishing. Not all of it's going to stick. Not all of it is going to make it, especially as we move into a time when people are not buying all of these products. But some of them are, and some of them are good improvements. Masks that are better designed for comfort, that masks that have some so offer some improvements over communication. I think NIOSH has a mission. It should take as its mission helping some of these small businesses continue to develop and improve on their designs. And there was a NIOSH DARPA sort of a contest for good designs. I think they should continue to do that sort of thing, but provide a lot more money to people who really have gotten fairly far. I do think that it's been a really good experience for the industrial hygienist, because we've had to think about infectious disease for the first time. And for those of us who've been thinking about this for many years, we've been sort of knocking our heads against the wall, trying to get even our community to really understand infectious disease. And it's different. It's similar and yet different, because it's the worker themselves who is infected and the source, as well as the person you want to protect. So that's a sort of paradigm shift in the way we think about exposure and protection. And I could go on, but those are the things that come to mind right now.
Well, I've got a quick question, sort of related, that came in from a listener. Given the widespread use of face covering, surgical masks, filtering face piece, can we expect to reduce the requirements for medical evaluation, training, and fit testing for respirators by members of the public? And I think that kind of wraps things up real nicely for us.
Sure. I have been pushing for and recommending when I talk with policymakers and others that we really do need to think about standards for public respirators for the public. And we have a new barrier face covering standard from ASTM. I was on the committee that helped develop that. We need to improve that standard. And I think at least what we need to require is that respirators for the public need to have similar types of filters as respirators, similar types of even lower breathing resistance. So, move towards the greater comfort. And they need to have been evaluated for fit on a panel of subjects, even if we don't do fit testing. But I also think we could be developing simple ways to help people fit test, something that they can do themselves. And the innovation has to be there. There are so many small sensors, for example, easy ways, probably, if we can just put our minds to it, to do fit testing. So I don't know about medical evaluation, but I think fit testing for the public could be here or sooner than later. And I certainly think better respirators, really, respirator-like masks for the public are around the corner.
I think that's a great way to finish this up. And we really appreciate you joining us again. And your passion for the topic is obvious. Dr. Lisa Brosseau. So thanks again. I'm sure we'll be talking again. Cliff will be putting out his blog. We'll put links to the documents we looked at and referenced in the blog. Before we go, I want to thank the Z-Man, my co-host, John. You got to have faith at the controls. Of course, this week's guests and our growing group of loyal audience. And by the way, next week, we've got Patty Harmon coming on. She's with Claims Magazine. We're going to talk a little bit more on the restoration side of things and some current events there. So please come back and join us next Friday at noon for the next episode of IAQ Radio Plus.
For IAQ Radio, I'm Spike Reel saying thanks for listening.